Thanks a lot, Dr. Satyamurthy, for having me here for this very useful course. I'll be talking to you on pearls for ACIOL implantation, and I have no financial interest. How does it go up now? Okay. I do not have any financial interest in my presentation. Now, ACIOL basically is a forgotten hero in cataract surgery. It is a very simple device. It is the surgical implantation technique is absolutely simple. It has earned a very bad name over the years, not because there is something intrinsically wrong with this lens, but because we have not been creating the proper intraocular environment for stabilizing the lens in the anterior chamber. And today we have been talking more about more glamorous stuff like glutean IOLs and different varieties of scleral fixated IOLs, iris fixed sutured IOLs, etc., etc. But still, this IOL has got its place in cataract surgery. Now, I just show you a series of videos and anterior segment pictures where the surgeon has made the fundamental mistake of not handling this lens properly. If you see this particular picture here, the lens has been flipped. This haptic should have come here. Proper anterior segment reconstruction has not been done. Peripheral anticyanic is still there, and then this lens is oversized. The corneal diameter was much lower than what this lens was really meant for, and the surgeon has not taken care to implant the properly sized intraocular lens. So basically, the surgical decision was very simple: expand the lens, do a little bit of vitrectomy to remove vitreous from where it should not have been, and then exchange the lens with a properly sized intraocular lens. These lenses come in three sizes: 13 millimeters, 12.5, and 12.5 millimeters, and 12 millimeters, and they can be customized. If you ring up the company, they can definitely customize a lens for you. So it is 1 millimeter more than the horizontal white to white diameter. This particular patient came to my clinic. Patient had undergone a small incision cataract surgery elsewhere, and you see the haptics, and you can see the knee of the haptic. These are all Kelman multiflex lenses, which are wonderful designs. It is projecting out of the eye. It is covered by the conjunctiva. So again, this patient had a problem. Cornea was getting decompensated superiorly, chronic irritation. So the anterior chamber lens picked up the blame, whereas basically it was the surgeon who was at fault. So I had a difficult time in separating the adhesions and taking out this lens and exchanging the lens with a properly fixated anterior chamber lens, and patient has been doing quite fine. These are a couple of videos you will see here. This is a patient with a double pseudophakia. AC lens was kept flipped, and when I wanted to do a vitrectomy, at least preoperatively B scan had revealed there was another posterior chamber lens which had dislocated into the vitreous. So this patient was both the lenses were removed from the eye. This particular patient had an ACIOL, lot of residual cortex. So I opened up the original incision. The flipped ACIOL was expanded out of the eye, and then after retracting the pupillary margin, I realized that there is adequate posterior capsular support. So here anterior chamber lens IOL was exchanged with an appropriate posterior chamber IOL after proper toilet of the anterior segment. This is another case where, again the AC lens was flipped, and the haptic of the lens, of the AC trailing haptic, had gone through the PI. One is in the posterior chamber. And this was a very young patient. You can see, the pupil was irregular. There was vitreous adhesion all in this area. So central area was clear. So I just decided to expand this particular lens. Explantation was not very difficult. First, the lens had to be rotated. The haptics had to be brought out of the PI, and then it was expanded. And subsequently, the patient has been left aphakic, and he has been quite fine. This is another thing which I still see, not fresh cases. Cases have been operated upon many years back. A posterior chamber lens kept in the anterior chamber, which is a strict no-no. Now, this particular patient I have seen at least 5 such cases. This particular patient had secondary glaucoma and chronic uveitis, and patient was in medical treatment. Patient had a vision of 6/6, and she refused any intervention. I have presented a paper titled Misadventures in the Anterior Chamber in this year's AIS meeting, which went up to the semi-final session, and then the ACRS meeting, and these presentations generated a lot of discussion. Here, I studied 7 patients had undergone SICS and 9 had undergone FACO. In 5 patients, the PC lens was kept in the anterior chamber, and in 11 cases, a inappropriate anterior chamber lens was kept in the anterior chamber. This is a flipped intraocular lens. The mouse isn't moving. This is a flipped intraocular lens. You can see, there's so much of pigment dispersion. The lens is pushed against the iris. This is what I'd shown you. All these pictures I'd shown you earlier. So the problem these patients are having is not definitely because of these beautiful Kelman design multiplex ACIOLs, but because they have not been operated up, they have not been handled properly. So 5 of these patients we manage conservatively because some of them are not willing for intervention, and some patients nothing could be salvaged. So patient was managed symptomatically. 7 patients underwent explantation. Repositioning was done for 2 cases, and in 2 patients IOL was exchanged IOL exchange was performed. Visual acuity improved in 4 patients from in the visual acuity range of 660 to 66, but improvement was not significant. So let us see how the antechamber lens should be handled. This is actually the proper orientation. If you see the trailing haptic and optic junction, it should be always on the left side. If you see the profile view, the AC lens is vaulted anteriorly. About 5-degree vaulting is there. Either it is vaulted or anterior step on the haptic. So this is the anterior surface and this is the posterior surface. Many surgeons mistakenly reverse this lens, thinking that the lens should be away from the corneal endothelium, and they reverse it. The lens is pushed against the iris, resulting in endothelium, and they reverse it. The lens is pushed against the iris, resulting in pupillary block and all the sequelae which I have shown you earlier. So this was another case where this was a case of dislocated IOL. Anterior vitrectomy was performed. Lens was removed from the same scleral tunnel. It was a referred patient, so we opened up the original tunnel, and this is the way the anterior chamber lens was implanted within the ACIOL was implanted within the bag. And we always like to keep these lenses in a horizontal position. So gently using a compression technique, the lens was oriented from in a horizontal position. So gently using a compression technique, the lens was oriented from the vertical to the horizontal position. And since anterior vitrectomy is performed, and a PI is definitely safer to perform because we won't like to be dealing with a secondary glaucoma postoperatively. So a small AAC PI, small surgical PI was performed. So basically, these are the things that have to be taken into account when we implant an anterior chamber lens. Age, we feel more comfortable in using these lenses in patients who are not too young. The ocular environment, I have told you, the proper anterior segment toilet, vitreous has to be removed, peripheral anticyanic have to be released. The proper sizing is important. I have already mentioned the importance of wide to wide diameter and adding 1 millimeter to that. And IOL handling, vaulting and orientation, which I have mentioned earlier. This was again, and this is how a good ACIOL should look like in the postoperative period. Certain situations where you would not like to employ an ACIOL is, when the cornea is not very healthy, as you see here in patients with cornea guttata or Fuchs dystrophy, where there has been iridodialysis. Even if you repair the iridodialysis, this is not the eye which should receive an anterior chamber lens. So, if you come across a patient with a wrongly misappropriate lens in the anterior chamber, it should be dealt with at the earliest. But we have no say over it. It depends upon when the patient comes to us. So all our emphasis should be on prophylaxis. So what do? Employ a good surgical technique, ensure that the complication rate comes down, manage the complications if they occur, perform a good anterior vitrectomy using a proper technique. If you are using an ACIOL, there are many other options. If you are using an ACIOL, make sure it is properly sized and proper vaulting and orientation are taken care of. Every case of cataract surgery that you do, you must have a standby ACIOL. In case you have a problem, this IOL is a backup IOL and the patient will not suffer in the bargain. The surgeons should also be familiar with the emerging techniques of employing secondary IOLs or different techniques of session of IOLs, which will be dealt with by other speakers. Thank you very much for your attention.